Morning, everybody. My name is Mark Philippon. I'm from Vail, Colorado. I'll chair this session, and I'm very happy to be here. I'm very impressed with the facilities and the speakers. So we have a great session this morning. I apologize. The first two speakers are in traffic, and so we'll go ahead and start with our third speaker. A great physical therapist from Australia, Miss Joanne Kemp. She's a research fellow at the Austrian Center for Research into Injuries in Sports and Their Prevention Federation University. She's also director and principal physical therapist, body system physiotherapy, Hobart, Tasmania. So I'm looking forward to her presentation. She'll talk to us about the non-operative treatment of hip pain, and we'll start right now.
Good morning, everyone, and thank you for the invitation to come. And I'd particularly like to say thank you to Adam and Per for what's been a wonderful conference so far. You might tweet and see the groin selfie. So today I'm going to talk about the non-operative management of hip pain. And I feel quite a little overwhelmed being bookended between some of the world's most recognised hip arthroscopy surgeons talking about the non-surgical management. But hopefully it'll be a nice complementary session. So we know that the hip and groin are commonly injured in young and middle-aged people. And one of those reasons may be that in some people the hip is commonly placed into positions of impingement, as we can see here. So generally flexion, internal rotation and some adduction. And in susceptible people, those impingement loads may result in intra-articular pathology. So we see things such as femoroacetabular impingement, or FAI, and the associated labral and chondral pathology. So that you have a hip that can look like this. So for today's talk, the type of hip patient that I'm going to talk about is the patient that we see who has a cam-shaped FAI, who has the associated labral pathology and chondral pathology. Because there are so many types of hip pain, I think it's important just to focus on one for the session today that's commonly seen. The other thing that I'd like to make clear at the beginning of the talk is that patients that have a cam-shaped hip on X-ray don't necessarily have FAI. So FAI refers to the pain and the pathology that occurs when that cam lesion impinges on the acetabular structures in susceptible people. So if we consider a typical hip patient who may present in our clinic and the timeline of the lifespan of that patient with regard to their hip pathology, studies have recently shown that people with the cam-shaped hip have a much greater likelihood of progressing to hip osteoarthritis in later life, and that can occur within 5 years. And so what we see is the young adolescent athlete between the ages of 12 and 14 who appears to develop the cam lesion during those growing years. When we look at studies of athletes in their early to mid-20s, these are the people who present with the painful FAI and the associated labral pathology. Once they get into their 30s, they present with FAI, labral pathology and associated chondral pathology. And ultimately, once they're in their 40s, they may well be that patient who has clinical hip osteoarthritis. And what we see in the literature is from that second time point, these patients present with pain, poor patient-reported outcome measures and physical impairments. So if we consider the shape of the hip joint, the morphology, the loads on the hip and osteoarthritis, we know that in the knee, suboptimal intra-articular knee loads, which are probably due to joint malalignment, are associated with an increased risk of knee OA. But we don't really know a lot about the contribution of hip loads to the progression of hip osteoarthritis. We do know, as we said, that both the cam-shaped hip and acetabular dysplasia are associated with an increased risk of hip OA. And it's thought that the alteration in the optimal or ideal hip joint loading in these conditions leads to alterations in the loads within the joint, which leads to micro-shearing within the articular cartilage, where you then get an alteration of the extracellular matrix. And finally, the chondral integrity is broken down, and this may result in hip osteoarthritis. But there are actually other factors other than the morphology of the hip that have the potential to impact on loads within the joint. So what are some of those factors that may contribute to loads within the hip joint? So what I'd like to do now is just a bit of a model that we've come up with of possible intrinsic and extrinsic factors that may well influence the stress within the hip joint and cause subsequent hip joint damage. So extrinsic factors that may have an impact on loads within the hip include the type of activity undertaken, the amount of activity undertaken, patient's body mass, and intrinsic factors can include things such as hip morphology, so FAI dysplasia, labral pathology, chondral pathology, hip muscle strength and hip joint range of motion, and gait biomechanics. And these factors all have the potential to be influenced by patients' age and their gender. And what we think happens is that the hip joint, when it's under stress, possibly undergoes reversible joint damage, but that, if the stress becomes too much, can progress to irreversible joint damage, the early degenerative changes that we see in the hip, and ultimately hip osteoarthritis. And that results in the pain and reduced function that we saw on the previous slide. Hip arthroscopy very nicely targets those hip morphology issues, so the things such as FAI, labral pathology and chondropathy. But I think it's important that we recognise that there are a large number of other factors that have the ability to influence stresses within the joint and possibly therefore alter that pain and reduce function, and maybe alter that joint damage that we see. So if we can target those impairments that impact on loads, that may be an effective treatment alternative to surgery in certain patients. So what evidence do we have for the non-surgical management? And to be honest, it's very minimal. So this was a systematic review that Damien's group published, where they looked at studies that, conservative studies for femoroacetabular impingement. There were very few studies, and the studies were of very poor quality. But the themes that came out were activity modification, physical therapy, a stage-based exercise approach, and treatment for the core hip muscles, education and advice. But there is no RCT evidence supporting the non-surgical management for FAI and associated pathology. So the best evidence we have to date, and this is what I'll focus on today, are studies that describe impairments in this population so that we can then use an impairment-based model to construct our conservative rehabilitation programs. This was a study published in BJSM last month where they looked at, it was a systematic review of the physical impairments in people with FAI and associated pathology. They included 16 studies, which were all cross-sectional or case series studies. And what they found was that range of motion in most of the studies was reduced in all planes, but particularly in internal rotation and flexion. That hip muscle strength, again, was reduced in all planes, but particularly reduced in hip adduction, abduction and extension. There was very little evidence on motor control changes. Only one study looked at functional performance, and that reported a reduced depth of squat in patients with FAI. There are a couple of studies on gait, and they reported reduced sagittal and frontal plane range of motion and reduced peak flexion, extension, adduction, external and internal rotation. This paper was published in JOSPT just last week, and what this study showed is that patients with chronic hip pain, so it included patients with FAI, but it included other patients as well, showed weakness in all of the hip muscles on the affected leg, but interestingly, they also showed weakness in their hip abductors and external rotators on their unaffected side. What about trunk impairment? We've heard a little bit about the trunk and the core yesterday from Christian. This study, which was published by Mark and his colleagues recently in the AJSM, showed that in a CT study, if the pelvis was in an increased anterior pelvic tilt, that increased the acetabular retroversion, reduced the hip internal rotation range of motion at 90 degrees, and also reduced that flexion internal adduction range of motion. So it appears that trunk control can alter the degree of impingement in the hip. Data from our group, which we are in the process of writing up, showed that patients with chondrolabral pathology after surgery had reduced performance in the side bridge test, which is a gross measure of trunk performance, on both the surgical and the non-surgical side, and that better performance in the side bridge predicted a better IHOT-33 score. So it does appear that trunk control can alter impingement. Also that people with impingement pathology have reduced trunk control bilaterally. So trunk control may also be an important target in our rehab programs. So what are the impairments that exist in people who have undergone hip arthroscopy for impingement pathology? We published this study recently looking at hip range of motion and strength in people with hip chondrolabral pathology after hip arthroscopy. And what we found was that patients with chondrolabral pathology had reduced internal rotation range compared to healthy controls, but people without pathology, without that chondrolabral pathology, were the same as healthy controls. For strength, the people with chondrolabral pathology had reduced strength compared to the healthy controls in most of the tests, whereas the no chondropathy were only weak in their hip adduction strength. And I think that's really interesting when we think of the context of many of the other presentations that we've had this weekend. We also found that women were weaker in abduction, adduction and external rotation, and that there was an interaction effect for pathology and gender for abduction strength. So if you were a woman and you had pathology, you had weaker hip abductors than a man with pathology and a healthy control women. So maybe the shape of the pelvis impacts on muscle function in these patients. We then wanted to look at whether these impairments predict outcomes in the people with the impingement pathology. And again, this is data that we're presently writing up, but what we found was that for both men and women, better hip flexion range of motion very strongly predicted better outcomes in men and women. In men, hip abduction strength was the outcome measure that predicted better outcomes. However, in women, greater hip abduction, adduction, extension and external rotation strength all predicted better outcomes in women. When we looked at the ability of these participants to balance doing a dynamic single leg task, what we found is that people with pathology had greater centre of pressure excursion side to side, mediolaterally, and also greater standard deviation of excursion in the AP plane, so they wobbled more in the AP plane compared to controls in a single leg task, a single leg squat task, so it appears that these people are impaired in terms of their balance and their proprioception. So to summarise the evidence for non-surgical intervention, we know that patients with FAI are impaired preoperatively, non-operatively and remain impaired post-operatively compared to controls. And these impairments include reduced range of motion, reduced hip muscle strength, which appears to be gender specific, reduced functional task performance, reduced trunk function, changes in balance and in gait. So now that we have a bit of an understanding of the impairments, what is the evidence for the non-operative treatment of these patients? Well, as I said, to date there have been no RCTs examining non-operative treatment for non-arthritic hip pathology. But I actually wonder whether we have actually had an RCT that we don't realise. We've talked a lot about this study in the last couple of days, the landmark study that Per and his colleagues published in The Lancet. And then this group followed up with these patients and went back retrospectively and looked at their bony morphology, so look at their shape and see where that fits in. What I'd like to do is just present things a little differently. If we think about the inclusion criteria of their cohort, I want you, as I present these criteria, to see what sort of patients they remind you of. So their mean age was 30 years. 61% of them had a gradual onset of their symptoms. 72% of them complained of severe groin pain. Their pain duration ranged from 3 to 48 months. 77% of them had ceased sport due to their pain. 33% of them actually developed radiographic OA in the 10 years after the RCT was conducted. And 58% of them had an alpha angle greater than 55 degrees. Is this a cohort of patients with FAI? The interventions that they did in that RCT, when we think about what we've just talked about in terms of impairments and the exercises that they included, they sit quite nicely. So the first phase consisted of adductor strength, core and trunk strength, balance activities and slide board activities. And then they would progress to hip add and abductor strength, core and trunk strength, pelvic stability and functional and balance training. And this was compared to a physical therapy group with laser, friction, stretching and TENS. And what they found is that those in the active treatment group had a very large adjusted odds ratio of predicting better outcome, and that the active treatment group were also more likely to have an excellent outcome. So if this is a cohort of patients with FAI, then maybe we already have some preliminary evidence that an evidence-based treatment regime works. So to summarise, I just wanted to go through what sort of things from the evidence that we have a non-surgical hip program should include. And if we think about the goal of our treatment as optimising hip joint loads, These are the things that we should think about. Working on the hip stabilising muscles and strengthening the hip, looking at progressive loading, sport-specific activity, balance and functional training and trunk function, optimising their range of motion, and I think most importantly, educating patients. So the hip stabilisers are generally considered to be the short rotators that sit posterior to the hip that tend to act in an external rotation, adduction and abduction plane. And it's considered that they have the potential to unload the anterior superior region of the hip, which is where most of this pathology occurs. So muscles that have the potential to unload that area of the hip need to have a line of force that's close to the joint axis that facilitates joint compression rather than torque generation, and also have a ratio of physiological cross-sectional area to length where they are shorter and fatter muscles, which Anthony Schack touched on the other day, that tend to stabilise the joint. So the muscles that the studies have shown that fulfil these criteria are quadratus femoris, gluteus minimus, the gemelli and the obturators. And there are various ways we can train them through isolation, loading and increasing the complexity. If we then think of strengthening our prime movers, we want to look at all muscle groups in all directions. And it appears from the evidence that all patients need strength in all hip muscles. However, there are some slight variations in that. So if we think about the planes of movement around the hip, it appears that for hip adduction, all patients need to be strong in their adductors, regardless of their pathology. For abduction, it's important in both sexes, but it seems to be particularly important in those with pathology. Flexion and extension strength seems to be particularly important in women with pathology. What about our progressive loading and our functional and balance and sport-specific aspects of training? We need to increase strength and endurance in these patients for them to be able to cope with the loads that their joints are under. It's important that these exercises avoid impingement positions, so are pain-free and are graduated, and include specific skills to their sport, so landing skills, cutting and kicking. How about restoring range of motion, particularly flexion? We have our soft tissue techniques, our manual therapy techniques, muscle activation techniques, and techniques for the lumbar spine and pelvis that all have the potential to improve range of motion. But just to put a caveat on that, I think it's important to remember that sometimes patients avoid flexion to protect their hip. So you need to take care with optimising range to not take them too far into flexion. And then finally, education in terms of load management, positions of impingement, pathology and prognosis and treatment options. We need to give patients realistic outcomes and appropriate expectations given the type of sport that they do, their gender and their pathology. I think we can assume that patients with FAI may have OA in its early stages and we need to treat them accordingly. So things that we know work for hip OA, such as weight loss, general exercise and joint-specific exercise should be included. If we think that OA has no cure, they should be undergoing these programs on an ongoing basis. And that, as we said, rehab programs should focus on improving flexion range, hip muscle strength, balance, neuromuscular control and functional and sport-specific tasks. With the position of impingement, and this is just a clinical perspective and I don't have any evidence for this, but I think that if you can take patients out of their position of impingement for 90% of the time in ADL, so encourage them to not sit on low chairs and not cross their legs, the cumulative load is reduced so that they can actually cope with going into that positions of impingement for short periods of time during their sport. We've talked about these things already. I think it's important to acknowledge that you need to tell people that whilst they will improve with whatever intervention you give them, they probably will never be the same as someone who has never had hip pain, and they need to be respectful of that. Finally, just to say that non-surgical treatment doesn't have great efficacy at the moment, and it may fail in some cases and often will require a surgical opinion. I think as non-surgical treatment providers, it's really important that we provide both patients and surgeons with a high-quality, efficacious treatment alternative to surgery. And at this point in time, the options are not great. So the take-home message is that our treatment goal should be to optimise hip joint loads using the current knowledge that we have of impairments. That physical impairments do exist non-operatively, pre-operatively and remain in people post-operatively for at least 12 months. So current protocols which follow people for 4 months may not be adequate for this patient group. We've talked about the things that they should include, but they should include these in an ongoing fashion, and that they should be tailored, particularly for patient sex and pathology, if we're going to optimise outcomes. And finally, that the level 1 evidence for non-surgical management is lacking, so we really urgently need RCTs looking at outcomes in this patient population. Thank you very much for your time.